Good evening. Today's video summarizes the most significant shifts in diabetes management based on the 2025 and 2026 standards of care in diabetes from the American Diabetes Association, ADA, and recent European Association for the Study of Diabetes, EASD, updates. 1. The Technology Revolution, CGM for All. The biggest shift is the move from selective to universal technology access. Broadened CGM access. Continuous glucose monitoring, CGM, is now recommended at onset of diagnosis and any time thereafter for almost everyone who can benefit. This includes all adults and children on insulin therapy, those on non-insulin therapies that can cause hypoglycemia, like sulfonylureas, individuals with type 2 diabetes, T2D, where CGM helps in overall management, even without insulin. Removal of barriers. The 2026 guidelines officially do away with treatment prerequisites, like C-peptide levels or a specific duration of insulin use, before initiating automated insulin delivery, AID, or insulin pumps. New CGM categories. Devices are now formally categorized into three types: real-time CGM, RT-CGM, over-the-counter CGM, OTC CGM, and professional CGM. 2. Beyond blood sugar, organ protection and obesity. Management has evolved from glucose-centric to organ-centric. Aggressive weight loss goals. The weight loss target for T2D has been intensified. A 5 to 7% loss is the new baseline to improve glycemia, while $check 10% is targeted for disease-modifying effects and potential diabetes remission. Obesity medication evolution. First-line choices. For T2D with overweight/obesity, GLP-1 or dual GIP/GLP-1 like tirzepatide/Mounjaro, are now preferred first-line pharmacological treatments. Individualized dosing. 2026 guidelines emphasize individualizing doses based on tolerability rather than just pushing to the maximum approved dose. Type 1 obesity. For the first time, GLP-1 and metabolic surgery are included as options for obesity in people with type 1 diabetes. Liver health, MASH/MASLD. There is a major new focus on metabolic dysfunction-associated steatotic liver disease, MASLD. Specific GLP-1 are now preferred for patients with T2D and high risk of liver fibrosis. 3. Heart and kidney health updates. New evidence has pushed for more aggressive preventative targets. Lower blood pressure targets. A systolic blood pressure goal of less than 120 mm of mercury is now encouraged for individuals with high cardiovascular or kidney risk. Dual therapy for kidneys. Guidelines now suggest the simultaneous initiation of an SGLT2 inhibitor and a nonsteroidal mineralocorticoid receptor antagonist, NSMRA, like finerenone, for adults with T2D and significant albuminuria to slow CKD progression. Heart failure. GLP-1 and dual GIP/GLP-1 are now recommended specifically for reducing heart failure-related symptoms in patients with T2D, obesity, and HFpEF. 4. Holistic care and complex scenarios. The latest updates tackle previously overlooked emotional and medical challenges. Diabetes distress. The EASD issued the first ever global guidelines on diabetes distress, emphasizing emotional screening at every visit. Cancer and diabetes. A brand new section in the 2026 ADA standards addresses glycemic management during cancer treatments, like immunotherapy or PI3K inhibitors, which can cause sudden, severe hyperglycemia. Cannabis warning. New, strong advice warns against recreational cannabis use in any form for those with diabetes, citing risks of cannabis hyperemesis syndrome which can be confused with DKA. Sleep health. Sleep is now considered a pillar of care. Getting 6 to 9 hours per night is officially recommended to improve metabolic health. Here is a detailed breakdown of the 2026 medication algorithms and CGM targets based on the latest standards from the American Diabetes Association, ADA, and the American Association of Clinical Endocrinology, AAC. 1. 2026 medication algorithm updates. The 2026 guidelines mark a shift from a glucose-centric to a complication-centric approach. Rather than just focusing on lowering A1C, clinicians now prioritize organ protection, heart, kidney, and liver, and weight management. Early combination therapy. Instead of starting with metformin alone, newer guidelines, like NICE 2026, recommend early combination of metformin plus SGLT2 inhibitor for adults with high risk of heart or kidney issues. Comorbidity-led choices. Heart failure, HFSGLT2 inhibitors, dapagliflozin or empagliflozin, are strictly first-line. Chronic kidney disease, CKD, priority is given to SGLT2 inhibitors or GLP-1RAs with proven kidney benefit, e.g., semaglutide. Weight/obesity, dual GIP/GLP-1RAs like tirzepatide, or high-potency GLP-1RAs like semaglutide, are prioritized to achieve 10 to 15% plus weight loss. MASH/MASLD, liver disease, GLP-1RAs with demonstrated benefit, e.g., semaglutide, are now recommended as initial therapy for those with liver fibrosis. Type 1 diabetes expansion, for the first time, 2026 standards support using GLP-1 receptor agonists in adults with T1D and a BMI greater than 30 to assist with weight and glycemic management. 2. CGM time in range, TIR, targets, 2026. Time in range, TIR, has evolved from a secondary metric to a formal therapeutic target that complements A1C. Population, target range, TIR goal, time below range, less than 70 mg per deciliter. Most adults, T1D and T2D, 70 to 180 mg/dl. 70% 4%, level 1, less than 1%, level 2. Older/high-risk adults 70 to 180 mg/dl. 50% 1%, priority on safety. Pregnancy, T1D, 63 to 140 mg/dl, 70% 4%, less than 63 mg per deciliter. Pregnancy, T2D/GDM, 63 to 140 mg/dl, 80-90%, very strictly limited. Perioperative, surgery, 100 to 180 mg/dl, 50% N/A, focus on stability. Sources, ADA 2026 Standards, LillyLink. 3. Key video highlights, what's new? Removal of pump barriers, Medicare and ADA now support automated insulin delivery, AID, systems without requiring C-peptide tests or a minimum duration of insulin use. TIR is a life metric. Every 10% increase in TIR is now officially linked to meaningful reductions in microvascular complications, vision, nerve, and kidney damage. Hospital targets, new specific targets for hospital stays, maintain glucose between 100 to 180 mg/dl and ensure TIR greater than 50% before elective surgery. This is for informational purposes only. For medical advice or diagnosis, consult a professional. Compiled search responses may include mistakes. References: Your Guide to the 2026 ADA Standards of Care, diatribe.org. Summary of Revisions, Standards of Care in Diabetes, 2026, PMC. Diabetesjournals.org. Which of these breakthroughs do you think have the biggest impact? Let me know in the comments. The video is just for awareness purposes and specific advice must be taken from the concerned experts in person before acting on any provided info. Don't forget to like and subscribe for your regular dose of medical and management news. Stay healthy, and I'll see you in the next one. Disclaimer: the video is for information sharing and awareness only. Facts must be verified before use. The creator, publisher, and YouTube will not be liable for any incorrect consequences/results.